Dear colleagues, good day. We are very, very happy to be here with you and present the joint international session on heart failure management in 2023. And in this session, we will discuss some questions about management and treatment of such a difficult group of patients with heart failure. And I'm very happy to introduce you our first presenter, Natalia Sonicheva, MD, cardiologist and co-founder of National Research Cardiogenetic League. Please, Natalia.
Thank you very much, Zalina. Good afternoon, everyone. I'm very happy to be here today, and thank you very much for the invitation. I think this forum is really a right place to talk about the future, which I'm going to talk today, and it's not such a distant future. I think it will come very soon. We're going to talk about gene therapy in the treatment of heart failure and cardiomyopathies. And I believe this is a really right audience of young cardiologists who will manage this future. So this is my disclosure. I'm a head of medical affairs of Tenaya Therapeutic Company, which is based in San Francisco. And this company is fully dedicated to gene therapy of inherited cardiomyopathies, which is probably the only one in the world which is doing this research. So we are going to talk about heart failure and cardiomyopathies and MAPPC3 associated HCM and AAV9-based gene therapy, which we are doing an attempt to the first in human clinical trial will start very soon. I'm going to talk about this. And PKP2 associated arrhythmogenic right ventricular cardiomyopathy and gene therapy perspectives in this field. So what the time is now for next generation precision medicine therapies focused on heart failure. Heart failure, as you all know, is still the leading cause of death in the world, although we have a lot of more options and we have SGLT2 inhibitors, but still it's a leading cause of death. And mortality rates are rising despite advances in standard of care. On this photo, on the right corner, you see the family of 7 patients, 7 people in the family, and 5 of them got a heart transplant. And you see the boy with just after heart transplant, they all have inherited dilated cardiomyopathy, very severe. So we would like to avoid it, avoid heart transplant and find a new way to treat these patients, especially with etiological precision approaches. And as you all know, heart failure, it's a syndrome, it's not a disease. So what we need to know the etiology of this syndrome. And this basically the way to the precision medicine and to the gene therapy. To know this etiology, we need to start doing genetic testing. Genetic testing will find the way, especially in family disorders, in familial dilated hypertrophic arrhythmogenic cardiomyopathies. We need to search what's the gene is and how to treat this gene. And there are increasing clinical validation for precision medicine. There are, you heard about the targeting approaches which are now using hypertrophic cardiomyopathy is cardiac myosin inhibitors. For example, mavacamten, which was approved recently in the FDA last year, and this year it was approved in EMEA in Europe. So we have already targeted approaches which didn't exist for 60 years. Hypertrophic cardiomyopathy was not treated or treated only symptomatically for 60 years. So now, finally, for the last year, we have targeted myosin inhibitors. But we need to go further. We need to go to gene therapy to treat a pure etiology of the disorders. How often heart failure is an outcome in cardiomyopathies? Here you see on the slide, this is the screenshot of the registry, TORCH registry. It's ongoing in Germany for all cardiomyopathies, mostly for dilated, but you also see the patients with hypertrophic and arrhythmogenic cardiomyopathy. And you see that the heart failure outcomes are approximately in 15–20% of patients, and a lot of them get heart transplant. 15–20% maybe is not so high, but these patients are really severe and have a nasty cause of the disease, and they get to the heart failure, or to the heart transplant, which we want to avoid for these patients. If you look at the results of the SHARE registry is the biggest registry in the world for hypertrophic cardiomyopathy patients. It consists of now 9,000 patients with HCM. So you see that heart failure composite, the earlier the symptoms start in patients, the earlier they develop heart failure. But you see that 47, 30, 17%, all of them develop eventually heart failure, regardless of age of diagnosis. Heart failure and AFib dominant and most prevalent after 50 years. And this is the window for disease-modifying treatments for these patients. The new paper just was published in Circulation in May 2023, also from the SHARE registry, which says about the prevalence of left ventricle systolic dysfunction. It was high in patients with childhood diagnosed HCM compared with those with adult diagnosed HCM, but it's still a very prevalent cause the outcome of HCM. And then if you look at this slide from Maron paper, last year paper, you see that it's also in high percentage of non-obstructive and especially in obstructive HCM patients. And we have already mavacamten for obstructive HCM patients, and we have nothing for non-obstructive patients. So it's a really high unmet need, which we need to consider. And even though they not all develop systolic dysfunction, there is a high percentage of patients with half-puff, and they also get heart transplant approximately 8 years after the disease symptoms start. So it's and 42, 45 years old patients get heart transplant. Of course, we need to find something which is better. Talking about hypertrophic cardiomyopathy, as you all know, most of the cases are familial cases, and the reason of the development and etiology are mutations in sarcomere genes. 60% of these patients have clearly identified mutations in genes, and the most common are MYBPC3 and MYH7 genes. And 57% of the cases, the disease causes mutations in MYBPC3 gene, which is regulatory gene which regulates MYBPC3 protein. And this protein, as you see on the left part of the slide, is a regulatory protein which is controls the coordination, the cross-bridging activity between myosin head, which connect with actin, and due to this cross-bridging activity, it moves sarcomere toward M line, and by this produces contractility. And when the regulation is incorrect, and normally it's due to mutations which lead to loss of function of the protein, they call haploinsufficiency. So if there is a loss of function variance, there is a lack of the protein. And due to the lack of the protein, it will lead to disorganization of cardiomyocytes, phenomenon of disarray, which you all know, and hypercontractility, excessive energy consumption, and hypertrophic heart. So gene replacement therapy concept is to deliver a normal functional copy of the protein into the heart. It calls gene replacement therapy. In MYBPC3 HCM, there are 3 types of MYBPC3 associated HCM, which lead by truncating variants. So the most severe form, really progressive and which really leads to heart transplant and death, is homozygous, compound heterozygous, when mutation in both alleles. So no functional protein, no regulation of myosin head, and really severe phenotype, which is normally dilated, not hypertrophic, or overlapping phenotype, dilation, and hypertrophy. So these infants, they live very short life, not more than 2 years. They don't survive more if they don't get heart transplant. So this is really unmet need, which need gene therapy because there is no other options. Another type is diagenic, when there are 2 mutations in 2 sarcomere genes. One of them will be in MYBPC3 and the other one in any other gene. And this decreased function of protein a lot and also leads to severe HCM. These patients normally develop heart failure very early in life and they need heart transplant by the age of 20. But these 2 cases are fortunately rare. Not so many patients have these variants. And what often, as we talked, 57% of the patients of HCM, this is heterozygous type, when mutation is in 1 allele. And the patient has 60% of normal protein. And this is a progressive heart failure, still very progressive. But again, it's appeared normally the symptoms late in life in adult population. So gene therapy introduces a working copy of MYBPC3 gene in the cardiac myocytes, which produce functional protein and restore normal cardiac function. There are 3 types of gene therapy. I'm not going to talk about all of them as I don't have enough time. Maybe in next symposium, we will talk about all 3 types. But today I'm going to focus on gene replacement therapy. As I said, to deliver a functional copy of the gene using AAV vector, viral vector, which is benign into the heart. Gene therapy, I believe, is still raises concerns among cardiologists, among other doctors, and among patients because of, of many reasons, mostly safety. People are still scared to hear about gene therapy and what it is. But if you look at this slide, there is an extensive and growing track record to AAV-based gene therapies. It's not only AAV9 on this slide, all gene therapies which are using AAV vector. And there is already 20 years of clinical experience in this field. Again, not in cardiology so much. In cardiology, which is just starting positively, but it's only beginning of the track. But 20 years, for example, Novartis made the Zolgensma therapy for spinal muscular atrophy. A lot of kids by today, 3,000 kids got just this one infusion of gene therapy, AAV9 gene therapy, which is very successful. And there are other treatment ophthalmology, hemophilia. Just a new drug was approved in November last year for hemophilia and other treatments. So gene therapy is very up to date, and it's a good innovation, which hopefully will find a way and we will use it more often. It won't be any concerns in the future. And to provide the healthy copy of gene, which I'm talking about, we need a vector. A vector normally, this is on this slide, you see AAV vector. There are 12 different serotypes of the vectors. When we talk about cardiology, it's normally AAV9 type of the vector, which has a specific sensitivity and transduction to cardiomyocytes compared to all other organs. Although the word of virus, everybody understands that virus goes to the liver, which is normal and natural, but this virus, vector virus, is benign. It's just like a vehicle to use for gene therapy. The DNA of the viral vector is taken out and transgene is inserted in this, you see, it's pink color, transgene. It's not viral DNA, nothing from virus, only DNA or only the copy which we want to insert. There is a specific promoter which helps the transgene to go into cardiomyocytes in our case and to do translation of the protein which the heart needs. So it's really like a machine, like a car, to drive the healthy copy of the protein into the heart. It's benign, again. It's very important to remember how it works. So this vehicle, which we have, infused by just one in the life infusion. Imagine just one infusion in the life, and and the disease hopefully stops. It's beautiful. So it's just one infusion, which normally lasts for 4 hours. The patients before this infusion normally got immunosuppression, like 3-4 days of prednisone and sirolimus, different programs for immunosuppression. But it's important to give immunosuppression because it's still virus. It still goes a little bit to the liver as an all virus, but the immune system should be suppressed. We need to have immunosuppression for these patients. So then the vehicle goes to the, see, I think this slide is better. So you see this is a cassette of AV9, which takes MYBPC3 gene, the whole allele, healthy allele. It's big, but it's exactly the right size for this gene. It goes into cardiomyocytes with the vehicle, goes into the nucleus. And now you have to pay attention. This is very important because you must have heard about CRISPR-Cas. And when we use CRISPR, this probably will be my next lecture, not this one. But when you use CRISPR, it's a biological scissors, which cut in human DNA mutation. In this case, we don't touch human DNA. It stays in a separate episome. Look, here's episome on the slide, which produces only this healthy protein. And you see the blue protein. This is a protein. DNA of human DNA is the same. Nothing, no side effects, no cancer, nothing. It just produces mutated protein which stays in the heart. But there is no overexpression of the protein. If you look to this slide, very important. You see the overexpression of RNA, but there is no overexpression of the protein, MYBPC3 protein, due to this tight regulation. So it's fine. And the preclinical evidence on mice, homozygous mice. You remember I showed in my slide homozygous type of MYBPC3 associated HCM, which is very, very, very severe. So we tried to test gene therapy on very severe mice to see the result. And you see the heart mass goes down significantly. The ejection fraction increasing again back by 35% absolute. And the survival rate, all mice died after several weeks without the treatment. But those who got transgene, they all survive, 100% survival rate. So now it's a very exciting moment. There is a first in human clinical trial, which will start basically in 1 month in America. The patients who are selected for this first in human clinical trial will be non-obstructive HCM patients, mutation carriers, symptomatic, all of them, adult, although we wanted to try in children, but first FDA requirement is to try in adult population. So, and they all will have ICD and low AV9 neutralizing antibodies. There will be 2 doses tested for these groups. 1 dose is low, second is medium, but it's important. Of course, the study endpoints are mostly safety, like always in phase 1, but also initial efficacy will be tested as well. And the results are anticipated in 2024. So it's a very exciting period. And a few words about arrhythmogenic cardiomyopathy, because in HCM, we still have already mavacamten, cardiac myosin inhibitors. We have some. In arrhythmogenic cardiomyopathy, which really often leads to heart failure, also in 15-20% of cases, we don't have any options. We don't have anything except beta blockers and ICD and heart transplant when it is heart failure. The leading cause, the most common cause of arrhythmogenic cardiomyopathy is mutations in plakophilin gene, PKP2. PKP2 is very important regulatory pleiotropic protein, which regulates, which is anchoring between cardiomyocytes, and it also involves in gap junctions, so electrophysiological signals during heart process and contractions. So it's not just this, not only gap junctions and anchoring between cardiomyocytes, but it's also influences sarcomere proteins. So it's pleiotropic, works in multi-dimensions, and it's very important for regulatory of absence of arrhythmias, of heart rate control. So the mouse which was used for preclinical trial, again, was homozygous mouse. But homozygous patients, they don't survive. They cannot live without PKP2. So the mouse was got tamoxifen, that was under tamoxifen transduction. And the therapy, again, it was AV9 therapy. It was delivering a healthy copy of the gene into the heart, cardiomyocytes. And if you look at the preclinical data, this is really amazing. While plakophilin rate is raising to the normal rate, it's also other desmosomal proteins are improving. And connexin 43, which is important for gap junctions and for arrhythmias, is also stabilizing. And here are the results. Arrhythmias totally disappear. You see untreated control mouse with a lot of different types of arrhythmias. And transgene mouse has a normal sinus rhythm. So it's absolutely functioning without arrhythmias. And RE also goes down, survival rate is high. And in my last slide, I love this slide. It's very interesting. You know that arrhythmogenic cardiomyopathy patients have fibrofatty replacement. They have a lot of fibrosis. If you look at the mouse, which we try to treat, control mice, they had a lot of fibrosis. In blue, this arrow, you can see it. And on the right part, it's gene therapy mouse, and it doesn't have any signs of fibrosis. And this is impressive. We don't know yet if fibrosis is disappearing. It's just remodeling, positive remodeling and reversible. We don't think so, and we are not sure. It's need to be tested. But we do know that in the mice which are treated by gene therapy, they don't develop fibrosis. And I think this is very exciting. So thank you very much. I hope it will be our future and our very near future, which we are really looking forward to have. So thank you.
Thank you. Thank you very much, Natalia, for this just very wonderful, brilliant presentation regarding the theme. I do think we'll move forward to the next presentation, and we'll have some, if we will have some questions, we will have discussion at the end of our session. And the next presenter is me. And we will talk about the role of surgical revascularization in chronic heart failure patients. Who benefits from this kind of treatment management? So, as Natalia said, chronic heart failure is a clinical syndrome. It's not a disease; it's a special disease. And in identification of the special etiology of the underlying cardiac dysfunction is very mandatory in this group of patients in the diagnosis of heart failure, because the specific pathology can determine subsequent treatment, of course. Coronary artery disease worldwide and in Russian Federation also is the main cause of chronic heart failure, including such risk factors as arterial hypertension and survivors after acute myocardial infarction. We know that early mortality rates were very, very declined, and survivors after acute myocardial infarction, they still have coronary artery disease, and they still remain at risk for subsequent episodes of ischemic myocardial damage, and of course, future loss of myocardium and possible progression of heart failure. Increased frequency of myocyte death with aging, it increases, and of course, as our patients with chronic ischemic heart disease do have a lot of comorbidity consequences and comorbid conditions, of course, the risk of progression of heart failure in this group of patients, of course, is higher. Myocardial injury might depress cardiac function, which in turn may cause activation of specific systems, of course, and the liberation of neurohormones. And in acute heart failure, these are adaptive and tend to maintain arterial pressure and cardiac function. And in chronic heart failure, these can cause maladaptive hypertrophic remodeling and apoptosis, which cause further myocardial injury and impairment of cardiac function. The biomarkers can provide an estimate of progression of prognosis and help in the identification of healthy people who are at excessive risk for heart failure. And biomarkers that are currently available reflect at least 7 pathophysiological processes operative in heart failure, and they help to identify the specific ones involved in individual patients and aid in guiding management plans. Also in guiding, for example, different surgical procedures and endovascular procedures in heart failure patients. After a cardiac injury, we know comorbidities and various pathophysiological mechanisms contribute to left ventricular remodeling and heart failure, of course. Strategies to improve patient care beyond currently available treatment algorithms should, we think, include novel diagnostic, improved and treatment-specific patient selection, as well as novel therapies. And of course, we should think about genetic replacement therapy, of course, also, and the assist devices also, of which we'll talk, Sanina will talk about. And left ventricular remodeling describes the heart's maladaptation to mechanical, neurohormonal, and inherited changes by regulating ventricular size, shape, and function. To date, therapists have sought to improve mechanics and adjust molecular mechanism of remodeling, and novel treatment targets can encompass both strategies. In recent years, non-invasive cardiac imaging have significantly advanced, providing a range of accurate tools to characterize ventricular remodeling in this group of patients, in patients with globally heart failure, and is also including patients with heart failure due to ischemic heart disease. And as the methodology has evolved, clinical application have expanded, including the expansion of echo methodics and cardiac magnetic resonance to assess ventricular function and geometry using these tools. Potential imaging targets are listed on this slide. You will see it in the gray circle in the center, and imaging visualizes the presence or absence of upregulated pathways in the myocardium and interactions with other organs. Imaging signal strength predicts individual adverse outcomes and progressive myocardial remodeling. And of course, repeat imaging may be used to monitor access. And the first-line strategy for avoiding maladaptive LV remodeling, which is presented in heart failure patients, is to treat reversible causes. And this one includes, and we will talk about it, revascularization, and it should be performed during both acute and chronic conditions. It should be that is one that you should think about the cardiologists and the cardiac surgeons. Changes in filling state, preload and afterload are important contributors to LV remodeling, and our goal is to improve patients' life. To date, therapists have sought to improve. Tests for viability and coronary angiography are essential, we think, prior to a consideration for revascularization when you plan the revascularization for each individual patient. There is no perfect test for nowadays with excellent sensitivity and specificity, and we need a combination of tests for decision making, as you see here on this slide. Which test to be used in a given medical center is influenced by the availability of tests, and this skill is performing and interpreting the result. And you see here several tools that can be used for cardiologists to plan again the strategy of revascularization in each patient. The scientific basis of revascularization is and especially surgical revascularization in this group of patients, in the ischemic cardiomyopathy patients, is based on the following facts. That revascularization of ischemic myocardium improves left ventricular, regional, and global mechanical and metabolic function. The successful revascularization has potential to induce reverse LV remodeling and increase in ejection fraction, and improvement of LV function after revascularization will impact long-term prognosis. Viability studies have revealed that the annual mortality rate is markedly decreased as compared with the group where only optimal medical therapy is performed for heart failure patients, ischemic cardiomyopathy heart failure patients. And decrease in mortality after effective and complete revascularization was also seen. Most of the studies of revascularization in this group of patients have been non-randomized and observational data, and compared CABG, surgical revascularization, with optimal medical therapy, and very few compared to kind of revascularization strategies, CABG and percutaneous coronary interventions. These randomized trials showed here on these slides, you will see the previous randomized trials that were performed, and these trials, this one, veteran affair trial, and the second one, and the third one. And in these trials, they have shown the superiority of surgical revascularization of CABG over medical management in patients with of course, multivessel disease, more so in patients with dysfunction of left ventricle, with perioperative mortality less than 6%. And the improved long-term prognosis is due to the recovery of function by stunned and hyperbind myocardium. The next one, this slide is about the CREDI-Kyoto trial and cohort 2 study that compared outcomes data between percutaneous coronary intervention stenting and CABG coronary artery bypass surgery over a 3-year period in patients with stable ischemic heart disease and ischemic cardiomyopathy with decreased LV function at a 3-year period. And patients that were included in this trial were mainly 3-vessel disease patients. Here you see the number of patients that were analyzed in this trial. And in 3 years, we see that in patients with heart failure with advanced coronary artery disease, CABG was a better option in comparison with PCI, because CABG was associated with better survival benefits, particularly in more complex coronary lesions. And this one was stratified in this trial, of course, by the Syntax 1 score. What about meta-analysis? Meta-analysis of available studies comparing different methods of revascularization, again, PCI versus CABG against each other, or medical treatment in patients with coronary artery disease and left ventricular ejection fraction. It was also performed and performed in the literature. And the present meta-analysis indicates that revascularization strategies superior to only optimal medical therapy treatment in improving survival in patients with ischemic heart disease and reduced ejection fraction. And between the two revascularization strategies, they also made an analysis not only between invasive and conservative strategies, but also between two kinds of revascularization procedures, CABG and PCI. And between two revascularization strategies, CABG seemed more favorable compared with PCI in this particular study. What about the main study in managing, trying to understand how to manage patients with ischemic cardiomyopathy and chronic heart failure, STITCH trial and STITCH ES trial? This trial addressed revascularization therapy in patients with variable degree of ischemic heart failure with primary endpoint of death from any cause. Death from any cause was analyzed primary, and the results at the end of 5 years showed no significant difference between intensive medical therapy alone and medical therapy with CABG. CABG showed better secondary outcomes as compared to optimal medical therapy, but further, the extended study, STITCH ES study, that avoided several limitations that were in STITCH trial, in main STITCH trial, it showed that at the end of 10 years, not 5 years, but 10 years further, rates of death from any cause, you understand that it's about a primary endpoint, rates of death from any cause from CV causes or hospitalization for CV causes were significantly lower in CABG group comparing with the optimal medical therapy group. So when some limitations of the main STITCH trial was avoided, and this was accounted by per protocol analysis, there was about 24 relative risk reduction in mortality with gaps comparing with optimal medical therapy. So, if we summary of all these trials, and the summary of all these trials will benefit of revascularization over only optimal medical therapy in this group of patients with ischemic LV dysfunction. Comparison of surgery with PCI reveals long-term survival benefit and decreases incidence of myocardial infarction with reduced recurrent hospitalization with CABG. So what the surgeons should also think about when they decide while they're planning a CABG procedure in this group of patients. Such factors may influence better results, improved results of CABG in this group of patients as off-pump or on-pump procedure is performed. The off-pump technique has been advocated in patients with left ventricular dysfunction and deep myocardial revascularization to minimize ischemic time and perioperative myocardial damage, but of course, more studies are needed. The use of arterial graft, and the evidence seems to suggest that the use of the second internal artery is not associated with improved survival following CABG among patients with left ventricular dysfunction. Also, they should think about use of preoperative aortic balloon pump in this group of patients. And at last, consensus on proper use on cardiac imaging. Should we use cardiac imaging and in whom and what algorithm to help determine the better candidate for surgical revascularization in patients with heart failure with reduced ejection fraction, and which candidates should be considered for revascularization has been limited by the absence of clinical studies that objectively and prospectively compare the prognostic information of each test obtained using both standard and advanced imaging. And this trial was just several months ago was presented in Europe. AIME heart failure trial is the largest randomized trial evaluating the role of standard, just only SPECT, and advanced imaging modalities in the management of ischemic cardiomyopathy and heart failure. And this trial will complement the results of STITCH, the viability sub-study, and PED trial, and the results will support, or maybe not, further advancement in and wider dissemination of alternative advanced imaging technologies. As you see here are some results that were presented as I said, several months ago, and there was no significant differences in the primary cardiovascular composite between the advanced and SPECT imaging groups. As I said, advanced is PET, CMR, and others. So, in summary, as we can summarize, CABG can be recommended in patients and is recommended in patients with multi-vessel disease and heart failure, in patients with, of course, acceptable surgical risk. So the cardiologist, of course, with cardiac surgeon in cardiac team, in heart team, should assess the benefit and the risk of surgical procedure in each patient with ischemic cardiomyopathy and heart failure with reduced ejection fraction. And until more randomized clinical data is available, it is desirable to follow the guidelines, European, American, and also Russian guidelines, where we do also have our own guidelines, Russian guidelines, with respect to revascularization in ischemic heart failure. I try to not be out of time, so thank you very much for your attention, and we can move forward, I think. Can you hear me? Okay.
Yes.
So the next presenter is my chairman, my very, I think, good friend, and I'm very happy to have you here today, Cristina Sanina, from Harvard Medical School, Beth Israel Medical Center, interventional cardiologist. Please have your time.
Good morning. Give me 1 second. Good morning, everybody. Thank you so much for the opportunity to participate in the Young Cardiologist Forum today. I'm going to talk about the patients with heart failure with reduced ejection fraction and mitral regurgitations. It's functional mitral regurgitation or secondary mitral regurgitation. I have nothing to disclose. And I'm going to start with the co-op trial. This is the main trial, basically, in managing patients with the heart failure with the reduced ejection fraction and secondary MR. And this trial, the idea of this trial started in 2014. The trial was open-label, multi-center, and it enrolled 614 patients. And the idea of the trial was to use goal-directed medical therapy alone, which included beta blockers, ACE, ARBs, and diuretics and spironolactone, or same goal-directed medical therapy plus mitral clip. And the co-op trial showed that actually the mitral clip, the left ventricular ejection fraction in this trial was the left ventricular ejection fraction in this trial was from 20 to 50%. And it showed that severe secondary MR in such patient population treated with the mitral clip improved the survival of the patient in 24 months, improved the quality of life of this patient, reduced the hospitalization for heart failure when it was compared to goal-directed medical therapy alone. Then this trial decided to continue, and per protocol, they actually prolonged the trial and allow the patient who want to cross over to the mitral clip group from the goal-directed medical therapy to cross over. And recently in March, they published the 5 years results of this trial. And as you see here, these were the baseline characteristics of the continuation of the co-op trial, 5-year follow-up. I want to just show you that 50% of these patients in both groups have prior myocardial infarction, 40% have revascularization with CABG or PCI. Then the etiology of heart failure, more than 60%. It's ischemic etiology, of course, and the MR severity was 3 or 4 plus, which is moderate and severe MR in 49 and 53%. Basically around 50% of the patients. And what it showed, this analysis of the trial, that mitral clip plus goal-directed medical therapy again did better for this patient, and it improved decreased the hospitalization for heart failure in this patient population over 5 years. It decreased the death or heart failure hospitalization in 5 years, and it decreased the all-cause mortality in this patient from 67.2% to 57.3%. And here is the slide which shows that in yellow, the patients which initially for 2 years were on just goal-directed medical therapy, they cross over, and as you see here, their mortality and heart failure hospitalizations became similar to the patients who had initial mitral clip procedure. So regarding the MR and basically survival, as you see here, that the patients who made it to 5 years checkpoint were the patients who basically stopped having severe and moderate MR, and because this is the patients who got analyzed, and they had mild or 2+, like basically a little bit mild, moderate MR. And this was a subgroup analysis, which also showed that in favor of the device, in favor of the mitral clip in this patient population, and regarding the EF, regarding the heart failure, New York heart failure class, regarding the hospitalization. So the conclusion of these trials were that the patients with the heart failure and severe secondary MR who remained symptomatic despite the goal-directed medical therapy and who underwent mitral clip, they did much better, and the mitral clip procedure improved their 5-year survival. And also these patients, it didn't really matter that what was the etiology of the cardiomyopathy and what was the surgical risk of these patients. The other thing was that treatment effects were reduced to after 2-3 years, in large part in 44.9% of control group patients surviving to 2 years. The control group had died before becoming, like half of the patients in the control group died before becoming eligible to cross over at 2 years mark. And there is another trial which actually took the co-op trial created the criteria of the co-opt patient. And this trial compared the mitral valve replacement therapy, also percutaneous versus mitral clip for secondary MR. And this trial actually showed that the real-world registry is not the patient from co-op trial. It's not only the patient who have the left ventricular ejection fraction 20 to 50%, and not the one who have favorable anatomy for mitral clip. It's other patients as well. And the real-world registry shows that the mortality in co-opt ineligible patients, so this patient would never made it to the co-opt trial, is actually higher compared to the co-opt eligible patients. And here again, I want to reiterate, so the co-opt eligible patients were the patients with the F 20 to 50%, with the LV and systolic diameter less than 70 millimeters, and the pulmonary artery systolic pressure less than 70 as well. And also, there's supposed to be the favorable anatomic and echo criteria for the tear and these patients who underwent TEER in COAPT trial, they were not eligible for any open heart surgery. So COAPT ineligible patients, these are the patients who do not meet criteria, and it could be that due to that EF is very low, or the patient the patient doesn't have echo and anatomic criteria for the favorable for the mitral clip. These patients, they undergo transmitral valve repair. And this is the several examples of the new valves which we now use for the severe symptomatic mitral secondary and primary as well, mitral regurgitation. And the study aim of this study, which is done in Germany, was to compare the transmitral valvular repair for the MR with the clip. There was no significant difference in the baseline patient's characteristics. They matched the patient characteristics from the TEER group, from the mitral clip group with the mitral repair in COAPT, and they divided these patients for COAPT eligible and COAPT ineligible. And they showed that COAPT eligible patients, the TEER actually did much better compared to the transmitral valvular repair. But in COAPT ineligible patients, the TEER and mitral valve replacement had no significant difference. So what the authors concluded is that if your patient basically is COAPT eligible, meaning that the EF is between 20 to 50%, it's a secondary MR, severe MR, and you have favorable anatomical and echo parameters, and the patient is not a candidate for any open heart surgery, the TEER improves the survival in these patients. And in COAPT ineligible patients, the TEER and replacement, it does improve survival, but it doesn't carry, compared to the goal-directed medical therapy, but it does not carry any difference. And I want to also mention the mitral regurgitation with the severe left ventricular ejection fraction decrease is patients less than 20%. So there is no clinical trials for these patients because this patient population carries a high mortality, and probably here in the United States, most of these patients will get advanced mechanical support or transplant. So it's only series of the which we can see and can read about, and it's very difficult where you know the degree of myopathy in this patient population when you actually fix the MR, and whether MR will worsen this myopathy and the EF becomes from 10%, and you can actually harm the patient. But in this series, they just took 15 patients, and they showed that these 15 patients, they underwent mitral clip procedure, and the mortality, the survival of this patient was 73% over 1 year. And one patient got LVAD, none of them got transplant. So generally, it's better survival than the patients who would have. It's better survival than the patients who would just be on the goal-directed medical therapy for reduced ejection fraction. And now I'm going to dive into the mitral valve anatomy and procedure. And mitral valve anatomy is a complex and dynamic anatomy, and the imaging is the key to understand the etiology and mechanism of the mitral regurgitation. As you see here, mitral valve has the anterior leaflets and posterior leaflets. Also, of course, the apparatus of the mitral valve, which includes chorda and papillary muscle. And here you can see the 3D imaging of the mitral valve with the TE, and the mitral valve we divide on scallops. It starts with the A1, which means anterior A1, A2, and 3, and P1, P2, P3. A1 is the lateral scallops, A3 is the medial scallops. And how we actually classify the etiology of the mitral regurgitation, we use the Carpentier classification, and as you see here, it has 3 types. Type 1, it's a normal leaflet motion, and annular dilatation is a type 1 with a normal leaflet motion, but they don't have a cooptation because the left ventricle is so dilated, so the chordae muscles, they're pulling down the valve, so the valve doesn't close. This is our secondary MR. This is our MR with the functional MR. The same type is the type 1 is the perforation of the leaflets. The type number 2 is excessive leaflet motion. It's a prolapse of the mitral valve or flail when you have a rupture of the chordae or papillary muscle mitral valve. This is all primary MR. And restricted leaflet motion when you have thickening or fusion. This is your mitral stenosis or calcification of the mitral valve. And the other one is 3B, is the LV or LA dilatation, which causes the annulus also dilatation. So through this classification, you actually can say where this is primary or secondary MR, or sometimes it can be both. And here again, this is the mechanism and the same types. And I just want to reiterate that and mention the STITCH trial, which Zalina mentioned as well, that the STITCH trial showed that the patient with the secondary MR, meaning the atrial functioning MR or ventricular dilated cardiomyopathy, who can underwent revascularization, they should also get the repair of the mitral valve because it improves their survival. And after we decided where this is the primary or secondary mitral regurgitation, we need to determine what is the degree of regurgitation. And this is the echo parameters which are crucial to measure and to determine, because these are the numbers. It's not only color jet, which you can appreciate. And it's effective regurgitant orifice area, it's regurgitant volume, and regurgitant fraction. And by these parameters, with this number, we can see where this mild, moderate, or severe MR. After that, we need to decide what stage of the mitral regurgitation patient is. So we treat and curate guidelines from ACC and AHA. They state that we need to treat the patients with stage C and D of secondary mitral regurgitation. Stage C, these are the asymptomatic patients with a severe MR by the echo. And D, stage D, this is asymptomatic patients with a severe MR. All these patients, they are already on goal-directed medical therapy for at least 6 months. And this is a diagram basically showing you the flow. So when you diagnose the patient with a severe secondary mitral regurgitation and it's stage C or D, first, you need to start goal-directed medical therapy, and the patient needs to be seen by the heart failure specialist. So in the patient with the stage D, right, so it's a severe symptomatic mitral regurgitation with ERO more than 0.4 centimeters square, if this patient can undergo CABG, because 60% of this patient is going to have ischemic etiology of the UMR, they should, because this is a stitch trial and it shows that this patient benefit much better from the CABG plus mitral valve repair compared to the other available treatments. But if they cannot, then you see what is the ejection fraction. If the ejection fraction is the more than 50% and the patient is favorable for the open heart surgery, and he's already more than 6 months of goal-directed medical therapy, and you treated this patient for atrial fibrillation, then go ahead and send this patient to the open heart surgery for mitral valve repair. If the EF is less than 50% and you still have the persistence of the symptoms on optimal goal-directed medical therapy, and mitral anatomy is an echo anatomy, right, is favorable for the mitral clip, then the mitral clip is your choice of treatment. And if all this, if the patient can be still in this category, if the patient is still a candidate for open heart surgery, meaning that his surgical risk score is not very high, then mitral valve surgery is the better option for this patient. And now I'm going to tell you about goal-directed medical therapy, and for this patient with a severe symptomatic or asymptomatic mitral regurgitation, secondary mitral regurgitation. So the goal number one is to decrease the heart rate in this patient. So you can use beta blockers if it's not ischemic cardiomyopathy, and I mean, generally with just the beta blockers, and your target heart rate at rest is 50 to 60. Second important thing is that the patient should be in sinus rhythm, because atrial fibrillation of bladder, it actually dilates the left atrium over time, and it dilates the annulus, so your MR will progress. So if you can do the cardioversion, treat with or do the ablation, do that for your patients. Third is resynchronization therapy. You need to try this patient who are eligible for that therapy is the patient with the prolonged QRS or left bundle and EF less than 35%. And medical therapy is you need to decrease preload and make sure your patient is euvolemic. So it's diuretics and Entresto, decrease afterload. It's ACE, ARBs, or Entresto, and reverse LA-LV remodeling, which is spironolactone, ACE, ARBs, and Entresto. And I want to talk about Entresto because it actually it's, I think, the future of the goal medical therapy for the MR, not only in patients with the reduced ejection fraction, but with the normal as well. So this is a new trial, the proof heart failure study, which used the Entresto for the secondary mitral regurgitation in patients with a decreased left ventricular ejection fractions, less than 40%. And it showed, actually here, as you see here in the beginning of the trial, they have 9.1 plus 5.8. So these patients were with a moderate and severe MR when they were started on the doses they can tolerate of Entresto. And 1 year later, the MR degree actually decreased 3 times in this patient, especially in severe MR. So Entresto actually becomes a leader drug in the mitral regurgitation, secondary mitral regurgitation, and decreased ejection fraction patients. And they basically said that more than 50% of the patients with the severe MR and moderate MR had the improvement in the mitral regurgitation. The other important issue is for the goal-directed medical therapy is atrial fibrillation, and I want to explain you why. So when the patient has the fibrillation, then it's often that this patient has the myocardial infarction as well. They actually develop AR, then the LA becomes dilated, which further develops the annulus, and your mitral regurgitation progresses. So no matter what, you need to treat this atrial fibrillation or flutter. The patient needs to be in sinus rhythm in order to survive, because as you see here, where you put the mitral clip in this patient or you don't, the mortality over time increases if patients has atrial fibrillation. And this is the paper about the meta-analysis which showed that. And they showed that they combined all these trials, and they showed that even if you put the mitral clip in the patients who have the, let's say, the co-opt eligible criteria, and they're in AFib, you do nothing for their mortality. So atrial fibrillation is important, is crucial, and you need to treat it in the heart failure patients with the severe MR. And here I want to show you the mitral clip idea and evolution. It started with the Dr. Alfieri's stitch. He actually noticed that some of the his patients had the congenital double orifice valve. And this valve, with the time, actually became stenotic, but it never had mitral regurgitation. So he created this procedure, which in mitral regurgitation, he just stitched A1P2 and decreased the mitral regurgitation. And coming from now, there were different different mitral clips, starting with this flower-like mitral clip, and it migrated to the modern-day mitral clip and its modifications. And I want to talk about the echographic parameters for mitral clip visibility. So for our secondary MR, we're going to focus on that. The important two parameters, and coaptation depth and coaptation length. So the favorable parameters is when your coaptation depth is less than 11 millimeters. So you can actually grasp the clip here. It's going to grasp well this leaflets, and if it would be more, the clip will drown in the LV, or it will not do the grasp effectively. And also the coaptation depth. So the coaptation length is more than 2 millimeters. So meaning that you have at least 2 millimeters where the anterior and posterior leaflets, they actually touch each other. They're not far away from each other, so you can actually grasp the leaflets. I want to present to you a case of our patient with the secondary mitral regurgitation. This was a 64-year-old lady with a history of breast cancer, mastectomy, and chemotherapy. And she had presumed chemotherapy-related cardiomyopathy with EF 25%, severe MR, 4+, hypertension, hyperlipidemia, diabetes, paroxysmal atrial fibrillation, and she was admitted again last year for the heart failure exacerbation. Within 1 year, she had 5 ER admissions for heart failure exacerbation. So it was clear that something needs to be done for this person. She is stage D of mitral regurgitation patient. She is a severe and symptomatic patient. This were her vitals, and this were her home medication: apixaban, torsemide, losartan, metoprolol, goal-directed medical therapy. I'm sure that losartan was at the low dose because the blood pressure didn't allow her to go further, and sometimes they become very dizzy as well. And as you see here, she's in sinus rhythm. So she underwent 2 days IV diuresis, and this was the echo, which was done again, and the echo shows that you have, with the color Doppler, severe mitral regurgitation. It goes posterior jet. Here is a 4-chamber, which shows the same. As you see here, is mostly there is no coaptation, poor coaptation of the valve. And the read on this echo was that HEF was 25%, then LV and diastolic diameter was 5.1, ERO was 0.2, which is actually our moderate MR. The regurgitant fraction was 96, which is a severe MR, and the pulmonary artery systolic pressure was 34, which is a moderate pulmonary hypertension. And then we did the TE. TE is a better method to assess the mitral regurgitation and to make, you can see the valve clear, you can do the good measurements because you have alignment, a good alignment of the Doppler in TE. So TE is the choice of imaging for the MR. And as you see here, you see that you have the, again, the posterior jet, severe MR. This is a 3D echo, which shows that you don't have coaptation of the P1 and P2 and A2 scallops, and there was the calculations where that ERO was 0.4, which is a severe MR, regurgitant volume 54, which is your moderate MR, and again, moderate pulmonary hypertension. The mitral valve was classified, the mitral regurgitation was classified as the Carpentier class 3B, and which is annular dilatation and severe MR. And there was a reversal of systolic flow in pulmonary veins. So this patient underwent mitral clip procedure. This is the TE during the procedure. As you see here, 3D imaging. This procedure is done 99% under the TE imaging, and TE is the most important. If you have a good imager and good imaging, then the procedure is done very quickly. It could be up to 30 minutes procedure. And sometimes due to the imaging quality, the procedure can extend longer. And here you can see our posterior jet in the beginning of the procedure. Here we're positioning the mitral clip. We're planning to grasp the A2 and P2 because this is where actually the scallops, they don't cupped. This is another imaging which shows you the clip going through the valve. And this is a grasping of the valve. So it's the mitral clip is it grasps the leaflets and it's closed 60%. And at this point, we actually measure the MR degree and we measure the gradient. We don't want to give this patient the mitral stenosis with the clip. And there was a good result. It was the MR became basically +1 from +4, and there was not a higher gradient, so we decided to proceed and clip it. And and this is the final imaging, 3D imaging. Looks like Alfieri stitch, the double orifice. And as you see here, our MR became mild MR. So the conclusion I want to tell you about that the most important thing is to define the MR etiology, where it's primary MR or secondary MR, and severity of the mitral regurgitation by echo. You need to measure ARO, regurgitant volume, regurgitant fraction. Then you need to see the stage of the mitral regurgitation, whether it's stage C or stage D. You need to do something with these patients. They cannot be left alone only on goal-directed medical therapy, or you send them to the surgery if they're eligible to, or you do the mitral plate procedure, or you do the transcatheter mitral valve replacement. And the new drug in the goal-directed medical therapy is Entresto. And I think in the future, all these patients will be tried on Entresto at least 6 months before they're going to go for any kind of the procedure. And if the patient needs to have CABG or he is eligible for cardiac surgery, this surgical mitral valve repair has more benefit than as of now, just because we have more patients are done the mitral valve more fixed surgical than with the clip yet. And the patient, this is COAPT criteria, patient with left ventricular ejection fraction 20 to 50% who are not eligible for open heart surgery should undergo mitral clip. Thank you so much for your attention.
Dear Cristina, thank you very much. Very, very important presentation from you. Especially, I do really very interested in this theme. And I have a lot of questions, but we have no time, so we will move forward to next presenter, Maria Simonenko Fedorov from St. Petersburg, Almazov Center, and the presentation. Please go, Maria. Thank you.
Dear colleagues, dear co-chairs, thank you for the invitation to present at the Congress. So I'm heart transplant cardiologist and responsible for the follow-up in long-term and outpatient department. And my co-author is the chief of high-tech methods of heart failure research department. So I guess this is well known, the criteria for the diagnosis of end-stage chronic heart failure, which is obviously the myocardial dysfunction with developed chronic heart failure function class from 3 to 4 and persist severe symptoms in patients who are on optimal medical therapy, with whose prognosis in the next 1 year is not fine, and patients with a decreased tolerance to physical exercise. So here is our plan how to treat patients with chronic heart failure in end-stage heart failure. First of all, this is obviously optimal medical treatment. When it's not enough, we need to consider mechanical circulatory support implantation in this patient as a destination therapy or as a bridge to transplant. Otherwise, we need to think about palliative care in these patients. As we all know, more than 30 years of heart transplantation we have right now, but for MCS implantation, it's about 20 years, and we can see that after these 2 decades, the survival totally improved to nowadays. And chronic heart failure is well known for adults and the incidence of this disease in these patients, but we don't have a lot of information about chronic heart failure in childhood. And data and prevalence of chronic heart failure in childhood are not available right now. But as we all know, 1/3 of these patients with decompensated chronic heart failure is going to die in 1 year after it was diagnosed. And the risk of sudden death is 5 times greater for children with chronic heart failure. The same as 5-year survival of patients, children patients, is less than 50% in long term. So we have guidelines in Russia about the difficulties of how to manage chronic heart failure in pediatric patients. And it's quite easy to treat adults, to perform different kind of clinical trials in this group of patients comparing to children. And right now, what we do know, what we try to use in patients who has been prescribed, in most of all, is the same as for adults. And the treatment of chronic heart failure, we try to use the same drugs, but in a lot of ways, we are really limited what we can prescribe to these patients, or sometimes dosing of some drugs is technically impossible, especially to the infants. And we also have legal difficulties about prescribing some of the drugs to pediatric patients with chronic heart failure. So that is one of the things that we try to develop in the future, but trying to manage these patients, we need to use our experience from managing the adults one. According to HLT and the last register slides we have from 2019, but after that we had a pandemic and a lot of information wasn't updated after it. So we can see that during last 20 years, the MCS implantation increased considering what we had before. And one of the main devices that was implanted to these patients is LOAT. And the same we have for pediatric heart transplant patients. LOAT is one of the main MCS devices that was used as a support to these patients. It's well known in remarks profiles that can help us to determine the timing of implantation, mechanical security devices, and they're not different either for adults or for children. But what we do have in our center, estimating our statistical data, we know that there are a lot of patients who were admitted to the hospital, but only 50 of patients with different kind of congenital heart diseases had chronic heart failure, and there is a small percentage of patients who develop chronic heart failure end stage. And in long term, we can see not only those who were admitted to our hospital with chronic heart failure, but increasing the number of patients, we also can see that none of them having heart failure were indicated for heart transplantation, or it wasn't possible to perform it, because in Russia, we can't perform heart transplantation from children to children. It's allowed only to perform from adult donor to children recipients. That's why we need to consider height and weight and BMI of our children patients, right? And the same as a number of patients increased, the same we can see that the mortality was almost the same after 10 years of follow-up in these patients. And our heart transplant program was initiated 13 years ago, and since that, only 13 children underwent heart transplantation. This was from adult donors, and one of this child was an 8-year-old boy who was heart transplanted in India because of his age. But later then he developed really progressive cardiac vasculopathy, and he was admitted to our hospital later then, and at the age of 13 he was retransplanted. So considering we don't have a lot of time, I try to go a little bit shorter. The tasks when we need to consider MCS are the same. And we start from bridge to bridge, considering when patient had an advanced heart failure, acute heart failure, we need to think about ECMO. We don't have an impeller right now in Russia. And from ECMO, if it wasn't as a bridge to recovery or bridge to transplant, we need to consider a long-term MCS. As for now, we don't consider destination therapy of MCS for our pediatric patients, but for adults, we have this experience also. And these are the types of MCS that we have. Previously, back then, we had also the ventricular support. Right now, we can implant only ECMO or LVAD to our patients. But as we all know, during the last 20 years, there were a lot of modifications, new devices were developed. And moving from the first experience, and as I showed you on the first slide, the survival wasn't that great back then. 20 years of experience of LVAD implantation changed not only the device, but also the therapy that we need to prescribe the patients after MCS implantation. And this was also helpful in increasing survival of these patients and survival as a bridge to transplant and after heart transplantation for this number of patients. This is the algorithm that we need to use, considering where we need to implant to these patients the ventricular device or LVAD therapy, considering we use transthoracic echocardiography. And also we need to think considering the causes of heart failure. Because in case of myocarditis, first of all, we need to prescribe management in using ECMO as a short support. And if there was no enough effect to turn the ECMO off, we need to think about LVAD in these patients. But in patients with dilated coronary, in a lot of ways, we need to think about it as a bridge to transplant, or using LVAD if there are contraindications to perform heart transplantation in these patients. So here is the example when we of criteria for collecting child for MCS as ongoing therapy. First of all, we need to discuss comparing with adult recipients. We need to discuss not only with the patient, but of course with his family. And all of them need not only agree with such management, but also they need to participate, how to work that, what to do with such patient in case of his deterioration. And also they need to understand not only the benefits of MCS we're going to use in this patient, but also the risk of stroke, the risk of bleeding when we need to implant such a device. And body weight and height also affect our choice of what device we can implant in these patients, considering their age also. And right now, this was performed during last year as an action clinical trial. It was a multi-center network that was performed in children with chronic heart failure. According to them, was HeartMate 3 implanted to them. As you can see, they had really long-term follow-up, and only one death with implanted device occurred during this clinical trial, which also show how new devices improved and help to save not only the adults, but also this is our new experience, what can happen after device implantation in children. But contraindication is almost the same for children as for adults. And of course, if there is an infection after process, we can perform device. First of all, we need to treat an infection. Also, it's again about the BMI of our patients. Severe neurological deficit will be contraindication for these patients. Also, patients with neuromuscular disease can be considered as contraindication to implant MCS in this patient. And different kind of congenital anomalies that are going to have a poor prognosis, no matter how we try to save the heart and to improve heart function. Congenital heart disease, congenital different kind of diseases can also affect the survival of these patients, no matter how we try to improve his heart failure status. In case of adults, because we don't have a lot of coronary disease in children, but in case of adults, when there are complications for heart transplantation and you consider to implant a lot in these patients, you need also to think about what can perform simultaneously to improve the status of these patients, because it's going to be an open heart surgery. And during the trials, and one of them was published not so far ago, it was shown that the survival is a lot bad in these patients when it was considered to perform simultaneous operation instead of thinking of a lot plus stent implantation. And also was affected because of in CABG, we don't need to prescribe a lot of drugs such as anticoagulants or anticoagulants, and this was also helpful considering the platelet therapy. But when we're talking about MCS implantation, it's not only one cardiothoracic surgeon. It's really a big team. They need to work with this patient during this heart failure follow-up, during MCS implantation, after MCS implantation, any case after heart transplantation. And our team also involve not only surgeons, but also cardiologists, different kind of transplant coordinators, administration, but there are also difficulties not to implant device, but working with the children, and physiotherapists and nutritionists, and the engineer that can help in case there are technical issues with MCS that we implanted. But not only devices, the size of MCS devices have changed during last years, but also the therapy that you describe to these patients also have changed, and it affected the survival because the first devices associated after implantation with different kind of bleeding complications, and we don't see a lot of them right now after LVAD implantation. But the difference is between all the patients, heart failure, this is one population, heart transplant population is totally different, but MCS implantation, even this patient had a heart failure, we need to consider to discontinue diuretics in these patients and increase the number of fluid balance for them. But beta blockers, MRA, SEA, and ARA also we need to continue to be prescribed to patients even after this implantation. But in long-term survival of patients who were implanted with LVAD, we can see according to the trial that was published last year, became a lot better, and the number of different kind of events and complications became less than it was before, and they were hepatic or renal dysfunction, stroke, or infection, the same as device heart valve took place in this clinical trial. And the main cause of death that was on device therapy, this was neurological complications, but also in these patients is really important to check where the pumps are implanted to decrease the number of infectious complications in these patients. And as I've said before, not all devices were changed over the years, but you can see the decrease of complications because of a different therapy that was prescribed to them after that. And adverse events in children with MCS are the same as for adults. There are a number of strokes that always takes place, but on the recent HeartMate-3 according to recent trials, there were not a lot of them, no reports until 2021. No pump thrombosis and a really small incidence of right ventricular heart failure. And this is one of our cases. In 15-year-old boy was implanted HeartMate-3, and this is the difference when we talk about children comparing to adults. They have one heart weight while they cope with chronic heart failure, but a few months later, he was improved, but at some point, gaining his weight also affected, and the original settings didn't work well for now. So comparing to adults, you also need to check these patients all the time because they can grow, they can gain weight, and the device will not work well for them at this point. And resettings were also helpful to improve his clinical status. And this is an example of what can happen if patients doesn't take care about the implanted device, and that's why even after implantation, they can be discharged from the hospital, but they need to continue their follow-up at the center where it was implanted. And such infections, even they weren't took care enough, they could cause not only infection complications, but can be decreased their condition to the sepsis. And so in conclusion, the results of clinical trials during these more than 20 years of experience of implantation MCRs in patients from adults to children. First of all, there is efficacy as a bridge to transplant comparing to drug therapy in those patients who optimal medical therapy wasn't enough to improve their status, and they couldn't be heart transplanted right away. And the effectiveness of new devices also showed a lot difference from the original one, and this improved the survival of all our patients. And here are patients. On the left corner, you can see one of our women who had myocarditis, and she was included in heart transplant waiting list, but after the chemotherapy, after optimal method worked, she was excluded, and then we have 3 years later, she is fine and she wasn't transplanted. And our children who were implanted either from export, our Russian LVAD, and other therapy, also all these patients with MCS who are on this picture, all of them are still alive. Even this girl was heart transplanted almost 10 years ago. And here is our team from heart failure, pediatric specialist, and adult cardiologist. And this is, I guess, the success of all our team. Thank you.
Dear Maria, thank you very, very much. Very, very important, interesting information, unique for our country, for a generation of management of children, patients with end stages of chronic heart failure. Thank you very much. I was really enjoying it. So we are out of time, but I will ask several minutes just to conclude our session and give some work to our brilliant presenters today. Dear Natalia, please.
Well, thank you very much. It was extremely interesting session. Even though I'm on holidays, I decided to stay and listen to all of this, and I really enjoyed it. All the talks were brilliant. And I want to say particularly congratulations to Cristina with their work, because it's real pleasure to see how the Russian Center is advancing, and it gives a lot of promise. And hopefully gene therapy also will come to your center soon. So this was great. And all the talks, and thank you, Cristina, for your talk. Cristina Sanina, we have 2 Cristinas. So it was very interesting. And Zalina, and thank you so much. Special thank to you for organizing this innovative symposium. Hopefully we will do it more time. Thanks so much.
Thank you, Natalia. Dear Cristina, from your side. I was really enjoying your talk. Thank you.
Yeah. Thank you so much for this opportunity again. I liked all the talks. Actually, all the talks were dedicated to very sick patients. Actually, this patient mortality is very high. So the new therapies needed to be done. The gene therapy, it's a very important direction. And the MSCs support the mechanical devices, what we have now. They save patient life literally, because we don't put them just in case. We put them when the patient is dying. And so this is also a very important area. And of course, our interventional techniques, which we perform for the patients who cannot undergo cardiac surgery. This still is not the primary treatment for basically all this cardiac acquired pathology, but we do well for now, and hopefully there are going to be more clinical trials which show better results, and we can understand better which patient benefit more from the therapies we offer. Thank you so much.
Thank you. Maria.
I guess this symposium was all about innovations that you can use all over the world. But at the same time, it wasn't only about new technologies, but all of us showed the new successful way how to treat patients, the new outcomes. And this is important, not only talk what we can do, but also share the results that it was successful and it improved the survival of our patients, literally end-stage patients.
Yes, agree in 100%. So thank you very much. We hope it was interesting. Thank you and have a good evening, everybody.
Thank you very much.
Bye.
Bye-bye.
Thank you.